Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchett. Today's episode features content from an educational program titled Contemporary Management of HIV. During this episode, Dr. Joseph Eron from the University of North Carolina and Dr. Daniel Kuritzkes from Brigham and Women's Hospital and Harvard Medical School discuss evolving issues in first-line antiretroviral therapy, including two-drug therapy, weight gain, and safety during conception and pregnancy. For more information on Dr. Eron and Dr. Kuritzkes, and for a link to the full online educational program, including downloadable slides specific to today's discussion, please visit the show notes for this episode. Now let's get started and hear what our expert faculty have to say about key clinical questions related to antiretroviral therapy initiation in treatment-naive patients with HIV.
We're going to talk about evolving issues in first-line combination therapy. There's some key clinical questions about first-line combination therapy. One is, can two agents be as effective as those regimens that we're very comfortable with that have three plus drugs for first-line therapy? And then the other question is, which regimens have the most compelling data? This big topic of how should we be considering the new weight gain data, which I think are, there's a lot of it, but we don't yet really understand things as well as we might like to. And then finally, what are the latest recommendations regarding dolutegravir use in persons of childbearing potential? So here's the case. This is a 28-year-old asymptomatic woman. She presents to your clinic after being recently diagnosed. Her physical exam is unremarkable, and she has no comorbid conditions. And you do have some laboratory results. You know that she has a normal CBC and renal function. She's essentially negative for hepatitis A, B, and C. Her virus level's only 22,000, and her CD4 is above 500. And you have her genotype back, and it's wild type. And she is interested in a simple once daily option. The issue is, well, we have now simple once daily options that and a once daily option that includes two drugs and that aren't in a boosted format. So these are the Gemini data, Gemini 1 and Gemini 2, which was a comparison of dolutegravir plus 3TC to dolutegravir FTC TDF in treatment-naive patients over 96 weeks. They did have to have a viral load less than 500,000 to enroll in the study, and they couldn't have transmitted a drug resistance or pre-therapy resistance. And it's a very large study, 700 people per arm. And what you can see is that really they are virtually superimposable over 96 weeks. And in fact, at Glasgow just a couple of weeks ago, the 144-week data were presented. And again, the durability of the two-drug therapy held up, and literally the lines are very much overlapping. But there were some caveats to this. These are looking at the results by baseline viral load. On the left, you can see above and below 100,000, dark, I guess that's maybe blue-green or whatever, is the two-drug, and orange is the three-drug. And you can see above or below 100,000, there's really no difference. We actually recently published a paper looking at 100 to 200, 200 to 300, 300 to 400. There are even a few people that were above 500,000, and there was no difference. However, you do see a bit of a difference when you look by CD4 cell count. So above 200 CD4 cells, again, very, very similar results. But less than 200, 200 CD4 cells at baseline, there is a difference. Now, there's no difference in the proportion people that had a viral load greater than 50. So there was no difference in virologic failure or virologic non-response. And on the right is kind of a complicated analysis, but basically is looking at the results excluding people who left the study for non-virologic reasons. And you can see there's not much, there is no real difference across the study. Now, the IAS-USA guidelines that just came out that Dan mentioned do recommend caution in participants that have viral loads, CD4 cell counts at baseline less than 200. When one looks at the snapshot analysis at 144 weeks, so here are the data from Glasgow, you can see that they're 82 and 84% are remain suppressed at essentially 3 years. So really, less than 5% per year, or around a 5% per year virologic failure rate. And if you look at proportion that were greater than 50, there really is no difference, 23 versus 21. Remember, 700 people per arm. And the difference, there's no difference really in discontinuations due to AEs, et cetera. Now, the sponsors of the study have this a confirmed virologic withdrawal. So what that means is the people were withdrawn and had viral loads above a certain cutoff, I think is 200. And again, there's no difference. So numerically, slightly more with dolutegravir 3TC. It is important to point out that there was one patient in the dolutegravir 3TC arm who was non-adherent off and on and did develop an M184V mutation, which is the first patient on this study to develop a resistance mutation. And then also, subsequent to that, developed an integrase mutation, this 263K mutation, which is a dolutegravir mutation. So developed resistance. So this in phase 3 studies, as far as I know, this is the first person to develop an integrase resistance in a phase 3 study, though there was an example in a phase 2 study that the ACDG did. So, but again, it's one person out of 700 who is essentially non-adherent to their therapy. Oops, sorry, I gotta scroll down so I can get to where I need to go. We have had data for boosted PIs plus 3TC, 2-drug therapy. These are the Andes data, but really we're really trying to move away from boosted regimens. It's not surprising to me that this combination works quite well, but it's really not recommended by the DHHS or IAS-USA guidelines. So here are the DHHS guidelines. Dolutegravir 3TC is now recommended as initial therapy for most people with HIV, except, and these are the exceptions, if HIV RNA is greater than 500,000. Now that's not in the package insert, but it is in the guidelines. Clearly, if they're HPV co-infected and don't have antibody, or they're starting ART before you have resistance testing or the hepatitis B results back. There are other 2-drug options. We in the ACTG and then a very large study by the NEAT group looked at dolutegravir, or darunavir, ritonavir, raltegravir. We thought it would be great. It had some real limitations. I mentioned darunavir, ritonavir plus 3TC, and then the limitation of dolutegravir 3TC, which we kind of went through above. Dan, what are you doing, and what are you telling your fellows to do in particular? Should they be worried about this?
Yeah, well, as we'll get into, I think the data are unclear about what the cause of weight gain is and whether it's the drugs or other things, but clearly people do gain weight. So I think it's important to let patients know that they should expect that when they go on treatment, they're going to gain weight. And they may gain more or less weight depending on a number of factors, which may or may not include what drugs they're going to be getting, but also their own characteristics. And they need to be aware of that and to try and be careful about making sure they get enough physical activity and watching a little bit more carefully what they eat and how much they eat. And if they do experience weight gain, to let us know sooner rather than later so that we can think about ways of trying to alter the weight gain, the rate at which they're gaining weight, not necessarily by a change in treatment, but a change in lifestyle and just being more tuned into it.
Yeah, I think that's great, Dan. 3/4 of our audience say they consider the potential weight gain, but I approach it exactly how Dan said. I have not changed my initial therapy for most patients, which includes a second generation integrase. But one of the things that really raised our concerns here was the ADVANCE data. Now, ADVANCE was a study done in South Africa. So virtually all the participants were Black. I think they all were Black Africans. And half the participants were women, because that's the population that has HIV in South Africa. And just to state that the three regimens are dolutegravir FTC TAF, dolutegravir FTC TDF, and then kind of the standard, what we would call, a tripla in the old days, efavirenz FTC TDF. And on the left is change in weight in kilograms over time. This is the mean change in weight by the various regimens. And orange is efavirenz, light blue is dolutegravir with TDF, and dark blue is dolutegravir with TAF. Everybody has FTC in the regimen. And you can see there appears to be some difference. I personally think that TDF and efavirenz actually have some weight mitigating properties, but there's no proof for that. But these are people who on average had a CD4 of like 350. So some had lower CD4. So you'd expect some weight gain in the kind of return to health. And this is the men on the left. On the right is the women. So these are all Black African women. And you see this 10 kilogram weight gain. So that's 22 pounds. And that's the mean with dolutegravir FTC TAF. And there does appear to be a substantial difference, and a significant one, between dolutegravir TAF and dolutegravir TDF, all with FTC. And you see more weight gain in women than in men. And so this is kind of, made people anxious. And when you talk to people, all of us, I think, probably have had one or two people in our clinic that have put on substantial weight, 20, 25, 30 kilograms on treatment. And we worry about that. But we don't know for sure that the medicines are causing it. Now, this is a paper from Dan's colleague, Paul Sachs, at the Brigham. This is a really nice paper, done very, very well, using randomized data, and looked at weight gain. Again, this is the least squares mean weight gain. So basically mean change in kilograms. And you can see that people who got integrase were more than people who got PIs or NRTIs. And then one question, well, you just showed us these data with dolutegravir, maybe bictegravir is better. There isn't as much weight gain. But you can see in the middle that really dolutegravir and bictegravir behave really the same way. And elvitegravir CoBe is less. And then finally, all the way to the right, you see the various nucleosides. Zidovudine is associated with weight loss, and that's not a reason to prescribe zidovudine, because it's, people have lipoatrophy and lipohypertrophy in different parts of their body. For those of you who are old enough to remember all that. But there does seem to be a difference. Here's TDF in yellow, abacavir is a little bit more, and TAF seems to be different. And this, remember, there was a randomized comparison of TAF versus abacavir in one of the studies that was done by the sponsor, that would be Gilead. So TAF may have some independent effect, but as Dan said, we're not completely sure. And these are the kind of risks that were compared in various studies. And you can see that TAF had more weight gain than abacavir, more than zidovudine, more than TDF. The others were not significant. And then bictegravir, dolutegravir versus efavirenz, again, you see this weight gain. And again, here's the argument. It's not just the class. The different drugs within the class have different effects. Rilpivirine was associated with more weight gain than efavirenz, for example. So what do our guidelines say? Weight gain has been associated with the initiation of ART and subsequent viral suppression. The increase appears to be greater with integrase inhibitors than with other drug classes. I think that's a true statement. Again, is it cause and effect of the integrase itself, or is there something about how people feel on integrase inhibitors is unsure. Greater weight increase has also been reported with TAF than with TDF, and greater with doravirine than efavirenz. I think those are all statements that are true. What to do about it, I think, is much more uncertain. And we don't know whether this change in weight is associated with cardiometabolic risk. So I think there are growing data that there, as you might expect, if you gain weight, there is some risk of diabetes. The DAD study's shown that. The NA Accord recently showed that. So I think there is an association with diabetes. I don't think anybody's demonstrated an association with cardiovascular disease yet. Well, what about DHHS recommendations about integrase inhibitors in people of childbearing potential? Well, pregnancy tests should be performed. That seems like very good advice. And then what are in the guidelines is this: enable individuals of childbearing potential to make informed choices, and providers should discuss the risks and benefits of dolutegravir around the time of conception and the low risk of neural tube defects. That's what NTDs are. But there are new data, which I'm going to show you in a minute, because you really need to know these new data in order to have this discussion that the DHHS recommends. For women of childbearing potential who are initiating ART, if they're on effective contraception, dolutegravir is a recommended option. If they're sexually active but not planning to conceive, but not using contraception, dolutegravir is an alternative, and they would say that you should use the same approach with bictegravir, and you'd have the discussion in the orange above. And then if someone's actually trying to conceive, they would recommend a regimen preferred during pregnancy, and dolutegravir is an alternative. Now, in the April guidelines, this is the fall guidelines. In the April guidelines, dolutegravir is now a preferred agent for women who are pregnant once they're pregnant. And I think that our guidelines may change when the SAPAMO study data were presented at the AIDS 2020, the virtual meeting. And probably everybody recalls in May of 2018, our lives were disrupted and our patients' lives were disrupted when this SAPAMO birth outcome surveillance study showed an increase in neural tube defects among Botswanan women who conceived while on dolutegravir. So dolutegravir was already prescribed, then the women conceived, and basically the risk was almost 1%, 1 out of 100. But the numbers were small. This is really important. And it's somewhat ironic, of course, because this study was planned to examine efavirenz. Efavirenz actually, of any ART, has the lowest risk of neural tube defects, at least in the SAPAMO study. However, a year later, additional data showed that the number of new cases of neural tube defects, as they accrued more women who received dolutegravir, then the number, the proportion was smaller. And then by the summer of last year, this risk was down to 3 per thousand. So instead of being 9 or 10 per thousand, it was down to 3 per thousand. And but though the overall risk was still 1 per thousand, so it was still different. And what we saw this summer is that, again, more data has accrued with dolutegravir. There now are almost 3,600 women who've been exposed to dolutegravir during conception, and there have only been 7 cases. That means since April 2018, there's only been 3 more cases, and the rate now is just under 2 per thousand. And for the non-dolutegravir regimens, which is almost 20,000 women, it's about 1 per thousand. And this difference is no longer statistically significant. So efavirenz is even lower, right? Efavirenz is less than 1 per thousand. And there's still a significant difference, just barely, between dolutegravir and efavirenz, but the rates are low, and I think our guidelines will actually change, and I think dolutegravir may become okay for even women who are trying to conceive, as long as there's a clear discussion. The other thing that was presented this summer, this is by Lamek Chanula, who's a Malawian obstetrician gynecologist and works with the Impact Network. This group, the Impact Network, looked at 3 different regimens during pregnancy. So these are women who were pregnant. They could have started a regimen and been on it for less than 7 days, or they were starting a regimen during pregnancy. It was an open label trial. They had to be past the first trimester, and they were randomized to efavirenz, FTC, TDF, which would be a standard in the developing world, dolutegravir, TAF, FTC, or dolutegravir, FTC, TDF. And these data are important for 2 reasons. One is more data on dolutegravir, and 2, it's our first look at TAF during pregnancy. So neonatal death was more in women who were receiving efavirenz, FTC, TDF, and this was significantly different than TAF, FTC, TAF with dolutegravir. Interestingly, 2 infants were diagnosed with HIV in the dolutegravir, TAF, FTC arm, and 1 in the dolutegravir, FTC, TDF arm, there were none in the efavirenz arm, and this one bothers me. Of course, there was the mother's RNA was less than 40. One was not adherent, and that's not surprising. But if you look over here in terms of proportion, well, on the left, if you look, I'm pointing with the pointer, but on the left, if you look, in terms of the proportion of women suppressed at the time of delivery was greater with dolutegravir arms than with efavirenz arms. So that's important, even though there were no transmissions in the efavirenz arm. And then if you look at adverse outcomes, this is over on the right, what you see, I think, is that actually dolutegravir, FTC, TAF was actually the best tolerated of the 3 regimens. So remember, the fewest neonatal deaths, fewest number of adverse pregnancy outcomes, 24% versus 32% in the 2 other arms, less preterm delivery, less small for gestational age, and a somewhat slightly higher, though non-significant, difference in stillbirth. So I think these data are, to me, suggest that potentially dolutegravir, TAF, FTC may be a very good regimen during pregnancy. So I've talked a lot, so we'll give Dan a chance to opine and give his opinions. So let's go back to our first patient. This was our 28-year-old woman, asymptomatic, diagnosed with HIV, interested in a simple once daily. Remember, she doesn't have hepatitis B. Her viral load is less than 22,000. Her CD4 is 500, and she's wild type. So Dan, would you consider 2-drug therapy in this woman?
Yeah, I think she checks all the boxes here in terms of eligibility. So certainly this is a person in whom a 2-drug regimen would be potentially appropriate.
Yeah, I would agree. I mean, I haven't used 2-drug therapy as initial therapy all that much. I have a lot of very treatment experienced patients, and that's who typically gets referred to me. But I mean, to me, this would be the perfect patient for that option. Yeah. So Dan, when would you not use dual therapy? When is it not a good option?
Well, I think it's really in those situations that we've sort of outlined, or that you've outlined in the talk. So first of all, obviously anybody who needs treatment for hepatitis B, A two-drug regimen that contains 3-TC as the only nucleoside is not a good idea. And we don't really have data on, say, dolutegravir or rilpivirine as a first-line option.
Right.
So where you could give that plus tenofovir or entecavir, which doesn't make a lot of sense maybe, but could be done. So those are the main things. And then I do think that, sort of anticipating the next question here, I do think that some thought has to be given about whether a two-drug regimen is really the best initial option for somebody with a very high virus load or a very low CD4 count. And those two typically go hand in hand. And so that's where I would say it's probably not a great option. Now, obviously, if you know that there's transmitted drug resistance, I wouldn't use it either.
Sure. Yeah, no, and I think those all make really good sense. And you're going to talk about this in a minute. I mean, it's not like if you want to start 3 drugs in someone with a low CD4 or a very high viral load or both, that you can't move to 2 drugs. And you're going to talk about that, so I'm going to leave off that. But I completely agree with you. I mean, it's not like we have a lot of toxicity in the first several months of therapy with 3-drug regimens, and I think being as safe as we possibly can. That's our So I agree with you. Though in this lady, it would be certainly a good option. And then this issue of weight gain. If this is let's say a Black woman who's at higher risk of weight gain, there maybe is some effective TAF here. You've already kind of said this already, Dan, but is there any impact of this weight gain and how you might use therapy? I know the IAS USA people subtly, and I was one of those people, kind of subtly moved back a little bit, right? Because we had TAF in our recommendations 2 years ago, and we kind of went back a little bit. We have TDF in our recommendations.
Yeah, I noticed that as I looked over the publication last weekend, and was a little bit taken aback. The issue to me is it's not clear to me whether the weight gain is really so much due to TAF as it is the absence of TDF, and whether TDF has some previously unrecognized weight suppressing effect, either because it has some effect on appetite that is not recognized or understood, or because it has some other metabolic effect through a pathway that we don't understand. So I don't know that if you look at large numbers of people that you're going to see huge differences in weight gain with and without TAF when you're initiating antiretroviral therapy.
Yeah, I didn't mention it, but in the Gemini study, where essentially you have dolutegravir 3-TC versus dolutegravir FTC TAF, there was FTC TDF. There was actually more weight gain in the dolutegravir 3-TC than there was in dolutegravir FTC TDF. So to me, that's telling you that TDF has some impact on weight gain, because that's really you have to assume that 3-TC and FTC are about the same. But yeah. What about women of childbearing potential age and use of dolutegravir? You're at home. You're at the home of leaders of that great study, which is a great study, by the way.
Oh, it is. No, it's really impressive what you can do when you have the kind of infrastructure that Roger Shapiro and his colleagues have built up in Botswana to be able to capture, such a huge proportion of pregnancy outcomes in a country is really a phenomenal achievement. As you highlighted, I think that the number of additional neural tube defect cases over the follow-up period in SEPAMO has been diminishing, and I would explain to patients that there is possibly a risk that other studies, for example, in Brazil, where many more women get supplementation with folate, showed no evidence of risk, although the Brazil data are not as solid as the SEPAMO data, not yet published, and that depending on the person's own feelings. Neural 2 defects can be screened for. And so, I am generally not averse to continuing dolutegravir and sort of follow the WHO line on this.
I mean, you could argue that, the alternatives, raltegravir, boosted atazanavir, et cetera, we actually have less data.
Absolutely.
We know precisely what the risk is in a setting where there isn't any folate. You can, I think, only assume that with folate supplementation, it's either the same or less. It's not going to be worse. And so we actually have better data for dolutegravir than we have for other things that we could consider. I mean, so yeah, I think I am totally on the same page as you.
Great. Thank you very much, Dr. Eron and Dr. Kuritzkes. And thanks to listeners for joining in. As a reminder, to view the full educational program, Contemporary Management of HIV, on the Clinical Care Options website, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.